Well, how do I follow that talk then? It's a bit tricky. First of all, I'd say that most of the things I was going to say have been said already. I couldn't have set the scene better for some of the issues that we have with this group of drugs. And what I want to do is talk about something I got asked to be involved in, which was a group looking at the prescribing of opioids in the west of Scotland. And what we decided as a group to come up with was a kind of guideline for good practice, which hasn't been approved as of yet, but I think will be improved by Greater Glasgow and Clyde. And what I would like to do, we did have a primary care representative, well, more than one primary care representative on the group, but I would like to really get a chance to get your views on what is enclosed in the guideline. It's all, I think, fairly common sense, and it's all taken from national and international guidelines, so there's nothing really new in there. But it actually has a few challenges for us in a pain clinic or in secondary care, and also for you working in primary care. So I'd be interested in all that. And I apologise, one of the main sources of my slides is Dr. Mike Basler, and it's been a while since I've followed him in a talk, so there's a couple of pictures in here which I'll skip over because you've seen them already. So what I'm going to talk on is really the bit which I hope will become relevant to you in your day-to-day practice. As I said, Mike set the scene very well of some of the difficult issues that we're up against, but the day-to-day fact of life is that you'll be in situations where you have patients with chronic pain who are on step 3 opioids. Mike's already shown this kind of picture of the nociceptive, neuropathic, psychogenic types of pain, but what I'm going to concentrate really is on the management of patients on step 3 of the WHO ladder opioids, and the ones I've mentioned there in highlights are morphine, OxyContin and fentanyl. I thought I had an ambitious task until Mike's talk, and I think he had the ambitious task because he's set the scene really quite well. On the group there were representatives from chronic pain clinics in Glasgow and Clyde, Lanarkshire, Dumfries and Galloway, Forth Valley and anywhere else? Is it? Ayrshire and Arran, yes, Ayrshire and Arran. And also primary care representatives in the form of Dr. Roger Hardman was the GP involved. So we kind of had one side which was all the pharmacists saying you should be doing this, and then you had all the pain consultants saying, can't we give tapentadol and buprenorphine patches? And things like, no, I'm only kidding, that wasn't what it was like. But there was actually a really gratifying exercise to take the chance to go through and look at the evidence for, and review the guidelines for the use of these drugs in non-malignant pain. I don't need to put this slide up anymore because Mike's kind of answered the question about what the problem was with opioids and chronic pain and the many issues involved. And there's no way around it. It is a very difficult area, and you're dragged into a compromised situation a lot of the time with patients. And sometimes you feel almost like you're colluding in their bad practice, but it's very difficult to see a way out of the situation. So that's Mike's slide, which I'll pass over. I don't know if that's more of a disservice to Angela Rippon or the other guy you said at the end. Again, I can probably skip over this. Why do we use opioids? We use them with the hope of improving somebody's quality of life, with providing pain relief, that's what they're meant to do, but also along with that, improving their function, allowing somebody who wasn't able to work to return to work, to make them sleep better, to feel better. And sometimes, as Mike says, we're maybe drawn into prescribing them because there's nothing else to do and we're not sure if it's the right thing or not. And there are increasing concerns, and we're in a climate now where there are far more concerns being raised about opioids. But 10, 20 years ago, we were actually being vilified for denying people pain relief and not prescribing opioids. So the climate has changed, and it's changed quicker perhaps in other countries than it has in the UK. But this has been an issue for a number of years, and I'll not go into this, but Mike has alluded to problems in America and Australia with the prescribing of opioids. And because we have a different healthcare system, then perhaps we don't have the same degree of problems. We can't have patients just shopping around, going to different specialists and getting drugs. So what am I going to talk about, or what is included in this guideline? Step-free opioids from the WHO ladder, and the drugs that are specifically mentioned are morphine, fentanyl and OxyContin. And what is not specifically mentioned, but we do give some guidance on, are tramadol, the buprenorphine patches, tapentadol and methadone. So, and what I'm going to do, now Mike's, sorry, I feel like I should be shielding my eyes there. Hi Mike. Mike's hopefully handed you out some of the things which are included in the guideline. And I realise it's quite dark, but it just might be handy for you to refer to some of these. One of them is a summary flow chart. So I'll just start by going through what we have said in the guideline. As Mike's alluded to, there's not a good predictor for which type of chronic pain or which person with chronic pain will have a good response to opioids. There was a vogue a few years ago for doing intravenous infusion tests, and if somebody had a very good response to an intravenous infusion of an opioid, that was a kind of green light that they would do well long term, and that's not true, and patients didn't get the same long-term effect as they would with an infusion. So we don't have an easy test we can do to tell whether subjectively somebody is doing better on opioid or not. These guidelines, one of the questions that Heather put up was, should opioids ever be prescribed in primary care? Or should be reserved for secondary care, and we discussed that. Basically, it's completely impractical. You might think some of the things that are included in the guideline are impractical, but it's completely impractical for every patient who is going to be starting an opioid to be managed in secondary care, and it goes against the whole flow of more and more management of chronic diseases in primary care. So these are saying that you can manage patients with opioids in primary care and initiate opioids in primary care, and it gives guidance when to include a pain specialist. They refer to Pain Society national guidelines on opioid prescribing and reference to international guidelines as well. Again, I'll skim through this because Mike's covered a lot of these topics, but if you are considering starting somebody on an opioid for chronic non-malignant pain, we're asking people to think about what is the cause of their pain. Do they have a definite diagnosis like very severe arthritis in an elderly patient which is inoperable, or are they younger with a kind of visceral pain syndrome or something which is not an exact diagnosis? Has thought been given to the kind of biopsychosocial aspects that Mike alluded to? Have other non-pharmacological and pharmacological treatments been explored before resorting to step 3? And as I said, this is all common sense, and I'm sure would already be happening, and a lot of this guideline is really just putting down on paper what is common sense. Have a think, could this patient have neuropathic pain? Because there are drugs which are used for neuropathic pain which we would recommend using before opioids. And overall, do you think a trial of opioids is appropriate? And one of the tools I've given you, which I'll come on to, is the opioid risk tool. We looked at various different tools to help people have a more objective scoring as to whether they think it's reasonable to prescribe opioids, and that's the tool we've come up with, which I'll come on to. But what we're trying to get over, again, and this is as much for us in the pain clinic as it is for you in primary care, is that if we do make the decision to try step 3 opioids, that it's more of a decision, more perhaps of a jump, and that it's done in a trial basis, and during that trial there's appropriate thought to initiation, but also monitoring during that trial as to the effect, and then a clinical decision is made at the end. We've come up with a time period of approximately 6 weeks as to whether you think it's reasonable to continue with that trial. British Pain Society highlight some groups which either do not recommend the prescription of step 3 opioids or would raise concerns. So groups that say not recommended, if somebody has had trials of opioids in the past for the same condition 2 years ago, don't try it again. They particularly mention sleep apnea as a condition which opioids can exacerbate, and again that's from a safety point of view, with increasing concern about the number of deaths of people who are on long-term opioids. And they specifically mention 4 groups which we included in our guideline as well. Not saying never prescribe in these groups, because we all know there are people who are prescribed opioids in these groups, but just stating that really there is no good clinical evidence for long-term effectiveness in patients with chronic headache, chronic back pain, fibromyalgia, or unexplained or undiagnosed chronic pain. One of the things that the guideline is trying to do is give guidance as to when patients should be more closely monitored, and it's a big issue. We have no way of, as Mike says, we don't have a database of patients who are on opioids in primary care. So one of the things the guideline is recommending is closer monitoring of some groups of patients, those with mental health disorders, depression, anxiety, previous existing addiction to any substance, or family history of the same issues. Now, I could just say that probably, the vast majority of patients in my clinic who are on opioids have at least one or two of these things. So, it's meaning we're talking about most patients who are on opioids. This is the opioid risk tool, which gives a score. And if you look down at the bottom left, it gives you a total score risk category of somebody who either is low risk, moderate risk, or high risk of developing dependence or addiction issues. And in there are things that, as Mike says, you would probably just have a gut feeling about, but it's just putting it down on paper. So family history of substance abuse, personal history of substance abuse, history of sexual abuse, psychological problems. Some of the wording's quite old-fashioned, but it gives you a score. And again, we're encouraging use of this to allow people to justify or to feel legitimate in saying, I need to more closely keep an eye, or I need to do this in conjunction with a secondary care specialist. So we talk a lot about consent, and again, the real world in the pain clinic is that we don't have time to talk about all these issues with somebody when we're suggesting opioids, although we try. And I realise in primary care with 10-minute or 7-minute appointments, it's going to be difficult, and that's one of maybe the issues with these guidelines, is they're in the ideal world. But if they're going to be brought out, I'm interested in your thoughts about how it could become part of day-to-day practice. But the discussion should include a clear explanation of potential advantages being on them, but also potential long-term disadvantages, side effects in the short term, and potential long-term side effects, and also advice on driving if you're on these drugs and operating machinery. And there's a link there to, there's a lot in there to a British Pain Society patient information leaflet for anyone who started on chronic opioids or opioids for chronic non-malignant pain. So even if it's a matter of clicking that, printing it out and handing it to the patient, at least that's probably more than it's done just now. I think it's very important. What we see just now is a situation where patients are already on maybe higher dose opioids than we would like, and they're already in the situation. The question is, could any of these situations have been avoided if there had been this discussion at the start, and more of a discussion about whether the opioids were on a trial basis and whether they would be, what would justify the opioids being continued or not being continued. And these are difficult conversations. I'm not trying to pretend that they're not difficult conversations, but the things we've talked about already are measurable pain reduction, improvement in sleep, function, and also, as Mike alluded to, any misbehaving with prescriptions, etc. Now, this is referring to the other tool which we decided would be useful to recommend for monitoring of opioids, which could be used, I think, in primary care or secondary care, and that's the PAD tool, which again I've got given copies out. And I couldn't get that to come up on the computer, so I'll just leave you to have a look at that. But basically, we would encourage that was completed during the initial discussion on starting opioids, and then during the 6-week trial, and then subsequently it's used as a tool to document benefits, problems, and side effects, and used as a basis for discussion with the patients. As I said already, we've recommended that the trial should be about 6 weeks, and that we realise is difficult because of problems with appointments, problems with patients not turning up for appointments. So that could be difficult. A clear expectation of what should be achieved during that trial. The the advice would be that all step 2 analgesics, and I'll come on to what they are, all step 2s from the WHO ladder are stopped and replaced with the opioid, but you continue with step 1, which is basically paracetamol and non-steroidals. So the step 2 analgesics that we're talking about are all single or combination analgesics containing codeine, dihydrocodeine, tramadol, and of course we're not allowed to recommend them because they're not approved, buprenorphine patches. But if somebody's moving to a trial of a step 3 opioid, then they should not be on cocodamol and tramadol as well as the step 3 opioid. These are the choices that we've come up with, and we reviewed the evidence for the use of different opioids for different types of pain condition. And to be honest, the evidence base isn't very good. So this goes along with national guidelines and international guidelines. What has happened is that the initial ceiling dose over time has come down. We would recommend that if you're considering opioid trial, you start with morphine, slow release, 10 milligrams twice a day, and increase by 10 to 20 milligrams every 2 weeks to a maximum of 60 milligrams twice daily. Oxycodone is basically twice as potent, so half the dose. And a fentanyl patch, we'll come on to the opioid conversion chart you've got there, but just to say that fentanyl patches are much more potent, I think, than a lot of people realise, and the starting patch, which is 12 micrograms, is actually equivalent to approximately 45 milligrams of morphine in 24 hours. So that's the order that we are recommending. Patients are only on one opioid medication, and we always recommend slow release preparations. Again, the evidence base for that isn't fantastic, but it makes sense not to give a short-acting agent with that can produce a kind of instant euphoria and reward type system, but give a medication which is going to last over a long period of time. And morphine's your first choice. If somebody is already on tramadol, buprenorphine patches, we've included an opioid conversion chart which includes them, and what we would recommend is that you work out the equivalent dose of morphine, and then to be on the safe side, reduce the dose by 25%, and that goes along with other guidelines in palliative care and in chronic non-malignant pain. And you're kind of caught between, it's not an exact conversion, it's a guidance. You don't really want patients to have withdrawal symptoms because you're not giving them an equivalent dose, but you really don't want them to have an overdose and get respiratory depression. And if morphine sulfate isn't tolerated despite treatment of their side effects, then the second recommendation is for oxycodone. We do not recommend any other route of administration apart from the oral route or transdermal. No injections, no pethidine, etc. And even for patients with swallowing difficulties, there's MST, which you can get as granules, which can be given before necessarily resorting to a fentanyl patch. We've given a 2-week kind of window as to when you would titrate the effect until you reach these ceiling doses. Now, the previous ceiling dose in primary care was 180 milligrams or equivalent of morphine. Now the guidance is 120 milligrams, and the thoughts are that if you're reaching that level or going above that level, it's far more likely that really you've reached the ceiling point and side effects are going to outweigh benefit. Always think, are you comfortable with this situation? Would you prefer to refer this patient to the pain clinic before taking this step? And you can guess which group put the lowest, most thing in there about ensuring most cost-effective brands are used. Thanks, Heather. The pad tool, again, you've got it in front of you, and I'd be interested in your comments as to whether you think it's something which is useful and usable. And it allows you to have a documented record of ongoing efficacy and potential problems. Now, the bottom line there perhaps should be in bold, but what often does not happen just now is that if the opioid trial is not successful, you feel duty-bound even so to continue with the step 3 opioid. And we see lots of patients who do not report really very much benefit at all, but actually when you try and start discontinuing the opioid, it proves very difficult. And even if patients where you have lots of alarm bells ringing, if they say that the pain is, that the opioids, they couldn't manage without their opioids, then even if you've got lots of alarm bells, you're kind of in a situation where you can't really stop the opioid. But then we're talking about, well, if you have alarm bells ringing, you need to think about how closely you should be monitoring the patient. So, further advice. There are no high-quality randomised controlled trials to suggest that morphine's better than, OxyContin's better than morphine, OxyContin's better than fentanyl. So, what we're saying is that there is no, if there's no clinical, if you get to 60 milligrams of morphine twice a day, there's no side effects, but there's also no benefit, then we do not recommend that you go on to a trial of oxycodone and then a trial of fentanyl. We were told we were being a bit too right-wing about that, so we've put in that in that situation, refer to the pain specialist. And now, as Mike says, what might happen is then that the pain specialist recommends a trial of another opioid, but I can't speak for all my colleagues, but that might happen. But at least there's further support, hopefully, in the situation then. If it's a good scenario and the patient reports that their pain is much better controlled, their function is much better, they're sleeping better, everything's looking good, then we say that after the 6-week trial, you monitor, you make an appointment to see them every 3 months to make sure everything's still okay, use the PAD tool, and then if everything's stable, every 6 months. And we just put in that every 6 months, review the situation, decide whether it's still appropriate, and consider a trial reduction in dose to see if the pain situation has changed and whether they still need the dose they're on. Situations when you refer to the pain clinic, in your initial assessment, patients with previous mental health problems, dependency or addiction. If you have difficulty after the 6-week trial reducing or allowing the person allowing you to reduce the dose of their drug. If you think they've got some slight response from the opioid, but you've got a feeling that they need a higher dose, we're saying don't do that in primary care, refer for a secondary care opinion. Basically, somebody who's got a difficult chronic pain problem, refer to the pain clinic, or if there's diagnostic difficulties. In the guideline, we're saying that it's good practice to avoid using short-acting opioids. Now, again, that is far away from the real-world situation just now, and because there is such a picture in palliative care or cancer pain management of using breakthrough medication and long-acting opioids, the same pattern has emerged for non-malignant pain. But we would very much discourage that if at all possible and use long-acting opioids or long-acting preparations. Keep the dose as low as possible. If the patient is reporting problems with of hypogonadism, so for women menstrual problems, for men impotence, etc., then you can check their sex hormone levels, and it may be that they're low. In that situation, the recommendation is that you or us refer them to the local endocrine service so that it can be further investigated and managed. And there is guidance here from the British Pain Society. If you feel from your assessment there's evidence of drug abuse, as to what can be done, and I'll come on to that. I'll mention this quickly. This is just, again, we felt this should be included in the guidelines, but basically there's local guidelines for the management of common short-term problems with opioids, or not short-term, but can be long-term: constipation, itch, and nausea and vomiting. And what we're saying is don't necessarily stop one opioid without trying to treat the side effects. Try and treat them, and then if they're still having problems, move on to the next one. A quick mention for patients with renal impairment. If somebody has significant renal impairment, there is an increased chance of them running into toxicity with opioids. So think carefully about whether they need them at all. Use the smallest effective dose, and in this situation we would recommend not using long-acting preparations in the first instance. We had a bit of debate amongst pharmacists and renal physicians about recommendations. There's kind of a big story that you would never prescribe morphine, you would always use another drug for patients with renal impairment. Actually, when we looked into the evidence for that, it's very, very poor in stage 1 to 3, and basically all opioids have a risk. and oxycodone is not initially any safer than morphine. So basically the take-home message is have a high index of suspicion. And in patients with stage 4 or 5 renal problems, we would recommend consulting the local renal physicians before starting the patient on an opioid. But general advice would be to avoid long-acting preparations, and where they are used, only use them once you've done a kind of dose-finding exercise with short-term preparations. These are some references for different guidelines that were looked at. It's not, I don't think it's all of the guidelines actually, but that's where we got a lot of our information. And this is the opioid conversion chart, which you've got in front of you. It makes interesting reading. It's the kind of thing that you can never, and I just hope I cut and pasted this, I just hope all the numbers are in the right boxes still. But it's not the kind of information that you retain easily, so it's quite useful to have something like this in your office. But what I would draw to your attention to is the top line is the oral morphine dose in milligrams in 24 hours, and look at the bottom, which is the transdermal fentanyl, and the 12 microgram patch is straight up there at 45 milligrams. So just be aware that transdermal fentanyl, the starting dose, is still a significant amount of morphine and is a significant jump from cocodamols or 3,500 cocodamols. So the guideline has been developed. It's been approved by the West of Scotland Prescribing Project Steering Group. I don't know who they are actually, but they have approved it as of last week, and it's now been taken to the Health Board medical directors of the various health board areas and the local Drugs and Therapeutics Committee, and in all likelihood it will be approved. Now, you may ask, well, what is the implication for me as a GP or a pharmacist in primary care? Well, I'm not sure. And because there's quite a lot in that guideline, and it means tightening up prescribing in quite a big way. It means big changes for us in the pain clinic as well. One of the things Mike alluded to is what can we actually do with this in sometimes very difficult situation. And one of the things we're looking at as a chronic pain managed clinical network is trying to get closer links with addiction services. And in January we've got our first meeting with representatives from the addiction service about perhaps a kind of service redesign or putting a business case forward for developing a pain and well, in Glasgow we've been calling it pain and addictions. In Edinburgh they call it pain and dependency clinic. But a pain and dependency clinic exists in Edinburgh just now, in Dundee and in other parts of the UK, but it's not something we have in Glasgow. But maybe we'll need one. So that's all I was going to say.